So my name is Todd Sevig, and I serve as director of our Student Counseling Center, Counseling and Psychological Services, here on campus. And I'm a co-chair of this conference with Dr. Srijan Sen. And on behalf of all of us here at Michigan, welcome to this Depression on College Campuses conference. The planning committee has done a lot of work. We looked at all those darn proposals you all sent in, and it was just beautiful to see it. And there is a spirit of re-engagement this year. This is our first in-person conference in 4 years. We had to cancel it at the last minute in 2020, and then the last 2 years we've had virtual conferences. So it's just a joy, and I can feel the excitement in me, and I see it in us, that it just feels different than when we have been online the last 2 years. So on behalf of all of us, welcome. I'm so happy and proud to be a co-chair of this conference. I have a lot of joys in my work life, and this is one of them. And after these 2 years, you know, we're back to not just in person, but more, we're back to those hallway conversations with each other, those engagements with each other in between sessions that we just did not do. We just weren't able to do it online, and it's a missing piece. I think in a lot of our work life settings, but especially this conference, because so much of it is built on connections with each other. You know, we were still together these past 2 years. We still cared about mental health. Nothing about a pandemic has changed that for us in now 2 decades, 20 years of holding this conference. And yet the richness of this conference can only happen in person. So that's the invitation. We've set the table, and the invitation is for all of us to dine together. So these last 3 years, it's hard to capture it, and I'm not going to try to do that, but it's been a period of unraveling, I think, of a lot of things. And yet the hope and promise among these 3 years, and now, maybe we're on the cusp of it, is raveling things back together in a new way, of reimagining some ways of providing support for student mental health, new treatments. And that's our hope for this conference, that it will be helpful in that process for all of us individually, but also collectively. We so appreciate you being here. One of the hallmarks of this conference has always been a multi-focus, multidisciplinary, multicultural, multi-roles on campus. We all have different roles on campus. And it's long been the vision that in order to advance our work regarding student mental health, we need all of us engaged on campus. As students, as faculty, as advisors, as mental health professionals, as researchers. So each year we have attendance from all of these areas, because college student mental health both does and needs all of us. Parents. I used to be one of them. Our kids have now graduated. Family members, roommates, friends. It really does take a whole village. Not just quantity, but it takes all of us in our unique roles on campus to make a difference, ultimately in students' lives. In a moment for John Graydon, who is here with us today. He was the longtime chair of the UM Department of Psychiatry and founder of the University of Michigan Depression Center, as well as now a national network of depression centers. This conference was his vision, his passion, and involved his leadership. That's worth some applause. I still remember our very first meeting in the Michigan Union about this. It just wouldn't have happened without him. And the conference has now, 20 years later, turned into something that I think we all agree is special, something unique and reflective of both the progress and the creativity and hope for the future regarding student mental health. It's very unique. Those of us who go to these kinds of conferences, It's very unique in terms of the multidisciplinary, the different roles on campus, the focus. Our profession in college and higher ed tends to be somewhat segmented. We always talk about getting together, but very rarely do we actually act like that. And this was always been part of the vision of doing this. So after all these years of having this conference and our time together, I would like to offer that I think our campuses are in a better place, providing mental health support and treatment. There's less stigma, although it still exists for some. There's more conversations, but more need to be had. There's more allocations of resources these past 20 years, but now we need to fine-tune where those allocations might be going. There's more awareness and more advocacy from faculty, staff, and students, but let's make sure we're hearing all voices. We now have a map that may not be totally completed, yet it's more filled out than 20 years ago. We are building this map together, informed by each of us as we share our findings and insights and successes and challenges and joys along the way. Yet there's still work to do, more advances as we dig out from our pandemics, as we navigate this hybrid world, thus the theme of this conference for this year. And while our experience today and tomorrow is important, the real value-added work is for each of us to enact and implement new ideas on all of our campuses, to learn from each other, to build on each other's ideas and work, and we hope today and tomorrow provides the stimulus for that. Finally, I would like to take a moment to acknowledge the work of Stephanie Salazar, who has been the engineer in making all of this happen. I don't know where she is, but let's give her a round of applause. She has the hard task of pulling the committee together, setting the agenda, making sure that we stay on track to result in these 2 days. So thank you, Stephanie. So the people may change year to year, the presenters, who attends, but this effort does not, and it's due to all of us working together, our collective approach. And so I invite us to take this in today and tomorrow. Let's have some fun, and let's do it. So thank you. And I'm now switching roles because I have the pleasure and the honor to introduce our opening keynote speaker, Dr. Lindsey Mortenson. Lindsey is the inaugural Chief Mental Health Officer in the Division of Student Life at the University of Michigan, a new role for us, and she has brought so much energy and excitement and ideas and vision to all of us working on this. And it's been just a joy to work with you personally. At UM, she also serves as the Associate Executive Director of the University Health Service and is a clinical assistant professor of psychiatry. She is interested in higher education, mental health access, quality, safety, and clinical informatics, and is the recent author of Systems and Models of Psychiatric Care for College Students, published by Springer in the book College Psychiatry, Strategies to Improve Access to Mental Health. So please join me in welcoming Lindsey as the opening keynote speaker. Thank you.
All right, good afternoon. If you would like to participate, please do in this poll. It wouldn't be a talk without a little bit of tech to start. It's totally voluntary, but I think it'll help give us a sense for who's in the room and the work that we have to do today. All right, let's see what everybody said. 50-50. So the question was, does your campus have a digital mental health strategy? For the 50%, oh, it's changing. Whoever said yes, please come find me at the conference. We don't have one at Michigan. We're working on it. I'd love to hear from you. Looks like it's going down. Thanks, everybody. I'm going to give this one more second. This is fascinating. Is this going to be the rule of thirds here? Okay. I see about 70% say no or I don't know. So this talk is for you, and hopefully there'll be something in it for those of you who said yes. And by the way, just like I said, come find me at the end of the conference. Okay, here's our talk for today. Digital mental health strategy in higher ed. What's yours, and why do you need one? These are some of the things we're going to talk about. And we're going to start with why. Why do you need one? This is a really timely question, and here's why. There is a revolution in service delivery happening around us and to us. We're a castle sitting on a foundation of shifting sand, and many of our castles are still very bricks and mortar in mental health. When it comes to mental health services, many of us still have a single location. We ask students to call for appointments, in some cases schedule online, to take the first available appointment with whoever will see them, and sometimes, yes, still ask people to fill out physical paperwork. And while we continue to provide good care in this model, digital front doors to care are opening up all around our students. Today, there are more than $700 billion worth of direct-to-consumer models with wide open digital front doors for health and well-being services. 700 billion. And while some of these services have passed through the typical filters and safeguards of the healthcare system and regulation, many have not. So how is this shifting sand connected to why? Well, without answering why, there is a risk of losing our way. You may have read this book by Simon Sinek called Start with Why. In it, he describes a strategy called the Golden Circle for getting things right from the start, whether it's a project or a new business. And Sinek's point is that too many projects start with what and how. Getting too focused on the what puts you at risk for, among other things, what is jokingly called shiny object syndrome in the tech world. Or if you're a bit tasky and workflow focused, like I am, you might jump right to the how. Both of these approaches miss the mark, which is the why. So let's take a moment to appreciate the truly unique historic moment we're in and why the why is so important. If we have any theater buffs in the crowd, or fellow English majors like me, you might appreciate this slide. Mental health services are undergoing unprecedented and existential change. We are in the midst of a digital mental health revolution. But here's the thing, in dramatic terms, we are only in Act 1 of what is usually a 3-act play. This is according to Tom Insel, the former director of the NIMH. He points out that we are in a young and emerging field. And just like in Act 1, now is the time when we meet new characters. There is an inciting event, COVID, and there is a plot development that pushes the story forward. Who are the characters in Act 1? So far, I can see a number. Telehealth, AI, virtual reality, and wearable technology, just to name a few. And true to the form of Act 1, we are already experiencing some inciting events. Some of these may be familiar. Excessive prescribing of controlled substances, data sharing, privacy breaches. All of these are creating tension and conflict in Act 1. It's been an eventful Act 1 so far, and we're only 3 years in. So what else are we seeing so far in this act? First of all, hundreds of thousands of people are receiving support and care through digital mental health innovations. In a recent meeting with Blue Cross Blue Shield of Michigan, which covers 4.3 million lives in our state, I learned that 50% of outpatient mental health care in Michigan right now is virtual and is not expected to rebound back to pre-pandemic levels. Virtually every other medical specialty has returned to pre-pandemic levels, but not mental health. We're also seeing the emergence of consumerism, scalable solutions, advanced analytics, and blended care systems that combined traditional in-person or virtual care with newer modalities like immersive and virtual reality. And there's also very, very high levels of investment, both from the private and the public sectors, $10 billion since 2017. So mental health is at the leading edge of digital health revolution, behind only probably radiology in the field of medicine, And the future so far is looking like more virtual solutions, not less. So now that I've introduced some of the key characters, I'd like to highlight some of the tensions in the air so far in Act 1. And Dr. Sevig mentioned one of these earlier. Stigma is less, but it's not yet broken. A recent large study published in JAMA Open found the first evidence of significant decreases in public stigma toward depression during the period from 1996 to 2018. That's something to celebrate. This is great progress, but we know that many students still struggle with help seeking and stigma about mental health support in particular. There's also not goodness of fit between the way our mental health systems are built and the way students want to access care. We'll touch on some of the things students care about later when we talk about value and quality. And finally, there's a lot to learn out here on the leading edge. So now that the stage is set for why you need a digital mental health strategy, let's talk about a few of the perspectives you may be bringing to all of this change. The first is your general approach to innovation and technology. In 1962, a sociologist developed the diffusion of innovation theory. And the premise is that with enough time, innovation gains momentum and diffuses through a specific population. We can all think of recent examples of this: smartphones, electronic vehicles, etc. Maybe you can see yourself on this curve. The innovators are the ones who love the shiny new things. The early adopters are the ones who say, hey, maybe I want that too. Early majority, that looks interesting, but is it for me? Late majority, what are those weirdos over there doing? Laggards, I want my fax machine back. Now there's an interesting break between the orange and the yellow, and it's called the chasm. And it turns out that new products only become mass market successful if they transition from being coveted by the converted, the ones on the left, to enticing the early majority. Many, many interesting products are not able to do this. So where do you usually fall on this curve? It's helpful to think about your general approach because it might affect how you think and feel about being on the leading edge of service innovation. Excited? Intrigued? Uncertain? Annoyed? Here's another factor that may impact your experience of these changes: when you were born. Now, generational cutoffs aren't an exact science, but their boundaries are not arbitrary either. Within each of these generational spans, there are key political, economic, and social factors that define a generation's formative years. For example, most millennials were between the ages of 5 to 20 when the 9/11 terrorist attacks occurred, and many were old enough to comprehend the historical significance of the moment. They were also between the ages of 12 to 27 during the 2008 election, when the force of the youth vote helped elect the first Black president in U.S. history. They also came of age and entered the workforce facing the height of an economic recession. By contrast, Gen Z has very little or no firsthand memory of 9/11. They are the most diverse and highly educated generation in U.S. history. And here's another important thing. For better or worse, technology has always been a part of their lives from the start. The first iPhone launched in 2007, when the youngest in Gen Z were 10 years old. Many in Gen Z have grown up in an always-on environment. So what's the takeaway here? A few things. Most, but by no means all, because I'm a Gen Xer finishing a master's degree, most of today's college students are Gen Z or millennials. We don't yet know what key events will define the next generation, but odds are that COVID will be one of them. And wherever you're working, whether it's higher ed or somewhere else, there are probably at least 4 generations in the mix, from the silent or boomer generation all the way up to millennials and Gen Z. Generational perspective and diversity are important considerations for digital mental health strategy. And finally, just like your spot on the diffusion of innovations curve, your own generational vintage may impact how you think about digital mental health and strategy. Another perspective you bring to this is your theoretical approach, or academic home. That might be psychology, social work, neuroscience, medicine, public health, health policy. Wherever your home is, it's important to highlight this one: public health. The major public health agencies of the world have taken notice of the digital transformation, as you can see. And so far, they seem to see it as a force for potential good, to improve outcomes, access, equity, and to advance knowledge. Another perspective is political and governmental. And as it happens, the US government is doing more than just taking notice. 1 year ago, President Biden created the Advanced Research Projects Agency for Health within the US DHHS. There's a similar agency called DARPA for defense projects. You may have heard of it. This year, ARPAH was funded with $1.5 billion. That's 500 million more than in fiscal year 2022. What is the US government spending money on? These 4 topics: feasibility, prevention, scalable solutions, and integrated systems in healthcare. There's a saying in higher ed finance: if you want to know what colleges and universities care about, follow the money. If that's true, I think it's safe to say the government is taking an interest here. And they aren't the only interested party. Insurers are becoming mental health providers, and retail giants like Amazon and CVS and others are investing heavily in the future of digital health. So it's fair to say it's having a big moment right now. The final perspective I want to mention is the one that is uniquely yours. The individual set of experiences that looks different for everyone, and yet can have perhaps the most profound impact on all of your approach to this work. My own sits at the intersection of these 3 circles. Like many of you here today, I have been impacted by the US mental health ecosystem. It is the most fragmented specialty in all of US healthcare. My first experience with this system was as an 18-year-old college student in the fall of my sophomore year, when I built up the courage once to call the campus counseling center. I was offered the next first appointment in 6 weeks, a span of time that seemed like a millennium in the context of a 16-week semester. I was going through pretty routine stuff. I understand that now as a mental health professional. Parents' divorce, medical retirement from the sport I'd been playing for 8 years, a breakup, feeling lost academically and socially, but it was happening all at once. And because 6 weeks seemed so long, I declined the appointment. And I never thought about professional help again until 8 years later, after a moment in medical school orientation that I'll never forget. The head of the medical school mental health program came to orientation, and while I'm sure he said a lot of things that day, what I remember is this. He said, "I look forward to meeting at least 40% of you in our office. Medical school is tough, and you're going to need some help." Those 2 experiences, separated by only 8 years, were pivotal moments in my why. And that moment in medical school was the first time I had ever heard anyone normalize professional help for mental health reasons. The second part of my why came later during 2 college mental health clinical rotations as a psychiatry resident, just right around here. It was in those rotations that I started to meet college students seeking evaluation and treatment for the first time, many of them after very long delays in care. Students with trauma, severe social anxiety and depression, and more. Some of the students were in their last semester of college and graduate school when they finally made it to care. And I'll never forget one of the first patients I saw. Unbeknownst to him, he had severe OCD that caused him to read and reread passages of text over and over for hours. He barely made it through college after several withdrawals, failed courses, and low grades. Why hadn't he been diagnosed earlier? What had prevented him from getting high-quality care? That student and many others like him has stayed with me. The last circle relates to the power of education and learning to improve quality of life and health outcomes. It's why I know many of you are here, and many of us have chosen to work in higher ed. I've been seeing students here at Michigan for 10 years now, and have had the privilege to see some of them transform from 18-year-old struggling freshmen to thriving graduate students. Mental health care has undoubtedly helped them to thrive academically and socially. It's at this intersection that I discovered my why for college mental health, that accessible, high quality, and equitable mental health services can unlock transformative experiences. For many, many college students, college is the time and place where they are able to get long delayed mental health care or to continue the care they started during K through 12. And for others, it's the last best time before they are launched into a fragmented, expensive, and inaccessible healthcare system. So now that we've set the stage, introduced some of the key actors and themes from Act 1, let's get back to the why we're wrestling with today. Why do you need a digital mental health strategy in higher ed? The why has a lot to do with these next 4 topics. And the first consideration is people. Technology is always secondary to what we're trying to achieve. It's in a supporting role to what is fundamentally a human endeavor. People are the reason we start with why. If we started with what, we might be at greater risk of shiny new object syndrome. And when you take a people-first approach, it makes sense that your digital mental health strategy probably won't end with a one-size-fits-all approach. Personalized care is an equity-first approach that ensures we are seeing the whole person and recognizing their individual needs. The same holds true for staff and faculty. Your strategy needs to address both the UX and the CX. I'm learning some of these tech terms. I've been thinking more recently about personalized approaches at the system level. Over the past couple of years, more students are saying things to me in clinic that they didn't say 10 years ago. Things like, I've done basic CBT and DBT, but what I really need is exposure and response prevention for my OCD and some coaching about relationships. Students of today are informed, experienced, and they know what they want and need. Not all, but many. Being person-centered also means understanding students at the population level. For example, according to 2021 Pew Research data, 96% of US adults ages 18 to 29 have a smartphone, and 70% have home broadband. These rates are even higher among people with some college or a college degree. So the students today are highly connected, at least when they're on campus. But what about the college students of tomorrow? Here are some important things to keep in mind as you're thinking through your digital mental health strategy. The mental health challenges of today's high school students are significantly greater than in the prior decade. Students who are Black or identify as LGBTQ+ report higher rates of attempting suicide and considering suicide, respectively. And during the pandemic, this one's sobering, 55% of high school students reported emotional abuse by a parent or other adult in the home, 11% experienced physical abuse, and 29% reported that a parent or other adult lost their job. That's 2022 CDC data. And just out from the CDC last month is this report on the screen. The latest statistics about rates of suicide, which are also sobering for the 10 to 24 and 25 to 44 age groups. After 2 consecutive years of decline in death by suicide, overall rates in 2021 returned to 2018 levels. In people older than 45, there were no noticeable increases, but there were very concerning increases in the following groups. For Black Americans who are aged 10 to 24, the rate increased 37%. For American Indian and Alaska Native, Black, Hispanic, and non-Hispanic multiracial Americans ages 25 to 44, there were double-digit increases in all those categories. But these are the students of tomorrow on our campus. So as you're thinking about strategy, get curious about people and population-level trends nationally, internationally, and on your own campus. You'll be in a much more proactive posture working upstream if you do. A final word on the people part of your strategy. The first is about design. The concept of human-centered design is relevant and important for your strategy. Health design thinking that is human-centered takes a 360 view of all the users, students, therapists, administrators, etc., of a product into account. And so you'll want to bring that perspective to new products you're considering and to your strategy. There are also important strategy considerations for our current and future mental health workforce. There's new technology, vocabulary, new conferences, new everything. Your strategy needs to include upskilling for current staff as well as trainees who are the faculty and staff of tomorrow. Next up is stewardship. This is a big one. Simply defined, stewardship is the job of supervising, managing, and taking care of something, such as an organization. Another definition I like is the careful and responsible management of something entrusted to one's care. And we're going to explore 3 essential aspects of stewardship for your digital mental health strategy. First up is time. As an administrator, I spend a lot of time talking about time. But the full impact of time and its role as a social determinant of health is something I've only fully appreciated since working in health administration and rolling up my sleeves to understand and improve the various clinic workflows that impact the student's experience of care here at U of M. Time is the single most important piece of feedback in patient satisfaction surveys. Time to make the appointment, lead time until the appointment, travel time, waiting time, duration of the appointment, time between appointments, time to getting a callback or a portal message reply. From all of this feedback, it's pretty clear that students put a lot of time into scheduling, waiting, and other logistics related to mental health care. And it's one of the reasons I was glad to stumble on this recent article which identifies time as a social determinant of health. You bet it is. It was for me when I was an undergrad calling the counseling center, and it still is for many of our students, whether it's to get an appointment on campus or in the community where it's still tough. Time is on everyone's mind, and it's inversely related to convenience. In a recent Consumer Trends report, convenience is the single most important healthcare factor influencing decision-making about where to get care. 80% of respondents are willing to switch providers just for convenience. And 77% of patients' comments on satisfaction surveys relate to time. If you believe that the time of your students, faculty, and staff is valuable, make sure stewardship of time is in your strategic plan. Next up is money. All colleges and universities have budgets, and some have more budget limitations than others. And so your strategic plan will need to factor in stewardship of the tuition and tax dollars that are entrusted to us. I hear the concept of price and cost coming up more and more these days as we think about sustainability. For example, what's the true cost of the apple you're eating out of season, or the pineapple that is not grown locally? We can bring some of this same curiosity to the true price and cost of mental health interventions, digital and non-digital. How do you know the true cost of delivering the value and outcomes we care about? As you can see, it's more than just dollars spent. By way of a quick example, how many of you have ever been involved in rolling out a new product or solution with a price of X dollars, only to realize that the true cost was more than you anticipated? Okay, I see a few hands. This happens to all of us because the true cost of new products always involves time that is unaccounted for, no matter how thorough your RFP or procurement process is. And when you start thinking about this price, cost, value trifecta, you start to see more clearly the reasons for some of the newer developments in the digital mental health space. For example, why are we suddenly seeing an emergence of payviders in the mental health space? Don't worry if you've never heard that term. I hadn't heard of it until recently either. Payviders are risk-based pay-provider collaborations that try to deliver value-based care, which is defined as lower cost, higher quality, better service. The biggest insurer in Michigan I mentioned a minute ago, BCBS and BCN, is now a payvider. They offer CBT directly and telehealth directly to subscribers. Why would they do this? Well, without the bricks and mortar overhead of a traditional practice, they can do it at a lower cost. Value is hard to find in healthcare and has been an elusive goal despite decades of efforts to transform the reimbursement, decision tools, plan design, care delivery, and economic valuation that prioritizes value over volume. And in the mental health space, it's even more challenging because we have a fragmented care system with a range of disciplines who all define quality a little bit differently. Either way, and getting back to strategy, with a well-established definition of value, now you can answer the question, is this a low-value or a high-value digital health product? And then you should ask, can we afford it? In that order. Value is an important framework for evaluating new and existing services, and it is an essential part of any strategic plan. So now that you know the equation for value, quality over cost, I encourage you to think about how you would define what high-value care looks like at your campus and for which populations. What do patients say they value? In a recent survey, these on the left are the top 10 things that emerged. They look a lot like the WHO list that I shared earlier. And importantly, the list underscores that some subjectivity and individuality in value and why it's so important to keep your strategy person-centered. Quality is where the rubber meets the road and where your digital mental health strategy could make things better, worse, or leave key outcomes unchanged but at a high price. What about low-value care? What does that look like? The U of M Center for Value-Based Insurance Design explains that low-volume services, quote, provide little or no benefits, have potential to cause harm, incur unnecessary cost, and waste limited resources. They are estimated to cause more than $340 billion annually in wasteful health spending. And the data, as you can see, about who is more likely to get low-value care is very troubling. What does this mean for your strategic plan? If you care about value and equity, measure it. Measure what you treasure. Incentivize it and build it into your systems of care. There are already 2 states in the US, Massachusetts and New Jersey, where Blue Cross Blue Shield is creating pay-for-equity incentives as part of their equity-based versus volume-based benefit design. The third and final leg of this stewardship stool is data. Data privacy, security, and literacy. Data breaches are on the rise. They can target emails, network servers, electronic medical records, and more. And unfortunately, healthcare is the most common target for third-party data breaches, accounting for 35% of all data breaches in the US, followed by finance and government. Some of this we know because the HITECH Act of 2009 requires the HHS Secretary to post a list publicly of all breaches of unsecured protected health information affecting 500 or more individuals. The most common root causes of third-party data breaches in 2022 was unauthorized network access, which accounted for 40% of cyber attacks on third parties. One cybersecurity firm attributes the increase in these breaches in part to the high numbers of people working remotely. I know that's not what we want to hear, but it does introduce a range of new data vulnerabilities. Selling data is also common. You might have seen the recent Washington Post article about mental health data brokers who are packaging customer mental health data for resale. Very concerning. Because of how complicated data, privacy, and security have gotten for all of us, many of us get caught up in what is sometimes called the privacy paradox. We care about privacy, we value protections, and yet sometimes we unknowingly behave in ways that put our own privacy and the privacy of others at risk. The same is true for students. There's a misperception that students who are digital native and in the millennial and Gen Z generations don't care as much about data privacy, but that's not what the data shows. A 2022 survey of US undergraduates found that only about half of respondents agreed or strongly agreed that they have confidence in their institution's ability to safeguard their personal data or that they trust their institution to use their personal data ethically and responsibly. There's an increasing area of focus. This is an increasing area of focus within K through 12 and higher ed, as you can see here, and recommendations are emerging that can guide your digital mental health strategy. When you're on the leading edge of innovation, learning is going to be a big part of the experience in your strategic plan. And while I do mean formal learning, conferences, classes, etc., you may need to consider a more programmatic and organized approach in order to change culture and encourage new ways of thinking. You're going to need this for Act 2 and Act 3. Why? Because many of us are currently sitting on the left-hand part of this spectrum in a very reactive and semi-organized posture. In tech and business, you can sometimes take the move fast, break things, and learn as you go approach. But since that's generally not the way we work in higher ed and healthcare and research, we need learning health systems that can continuously iterate, improve, and be responsive to the students on our campus. If you can, build a learning health system into your strategic plan. Leading health institutions in the U.S., the National Academy of Medicine, National Institutes of Health, and the Agency for Healthcare Research and Quality encourage healthcare organizations to become learning health systems in order to accelerate the translation of research into practice and to develop interventions that improve care and outcomes. The LHS model is a systematic, data-driven approach to learning and generating new knowledge to improve the quality and value of care. And it's exactly what we need out here on the edge of innovation. Learning is a great segue to the last key consideration for your strategy, and it's an important one. Governance and regulation have been a bit of a free-for-all for the past few years. During the COVID-related public health emergency, the FDA relaxed certain pre-market requirements for computer programs and mobile apps designed to support treatments of conditions such as depression, anxiety, OCD, insomnia, and others. This, combined with the COVID-related exigencies, have resulted in rapid innovation and rapid proliferation of new health and well-being digital technologies across a wide array of medical conditions that unfortunately do not have some of the guardrails in place around the areas of risk listed here. Why do we need these guardrails? Well, the culture of caution in healthcare, research, and education is usually for good reason. First, do no harm. And in the absence of digital governance, and with this many risk areas, harm is possible. It should be easy enough to create more governance, right? Maybe. One of the biggest threats to governance, especially in larger schools and colleges, is organizational silos. Don't get me wrong, farm silos are great. They keep large amounts of different materials separate, very practical. But silos in organizations will have downsides. Silos prevent resource and information sharing between departments and divisions. And the risk of this is high right now because digital mental health interventions sit at the nexus of healthcare, counseling, health promotion, education, IT, and other fields. So there's a lot of specialized knowledge and expertise that is both rapidly evolving and not immediately accessible and shareable because of the ways we work. So the timing is right for more attention to governance internally and externally. And it looks like external change is coming. Experts are predicting that tech and data privacy regulations will mature in 2023. What does data governance evolution look like? Here is one model on the right. My guess about present state is that for many of us, we're at different stages of governance with different tech products. Many may be relatively mature for the electronic health record, for example, but more reactive for newer products that have been recently adopted. So look for more on the regulation front. And in the meantime, dust off your governance documents, workflows, policies, procedures, and structures. You know, the fun stuff in administration. At UHS, we've started a new clinical informatics committee, in part for all the reasons that I've just described. These principles of good digital health governance from the HIMMS may help. The last slide before we wind up is about the technology lifecycle itself. It's a reminder about the importance of each of these key steps. They may require partnership, project management, or even new roles within your organization. Product launch is exciting, but as the saying goes, maintenance makes perfect. There you have it. 4 of the major reasons why you need a digital mental health strategic plan: people, stewardship, learning, and governance. And I'll end with a note about what comes next. We're headed for Act 2, which is the middle section of the play. It's where you encounter obstacles, complications, and usually a dark moment or two. We've already had a couple. In Act 3, we'll see resolution and a state of relative equilibrium. Based on our whirlwind review of history today, this new technological epoch we're in might last anywhere from 10 to 30 years. And when we get where we're going to a new normal, there's probably no going back. That's okay, because even with all the change in this new epoch, there are a few timeless truths I hope will stay with you as you leave and go through the conference. Education is transformational, and the work of mental health and well-being is endlessly interesting and meaningful. Now go get cracking on your digital mental health strategy. The students of today and tomorrow depend on it. Thank you.